Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Here's a number I want you to sit with for a second. 1 in 2 women over the age of 50 will have a fracture related to osteoporosis in her lifetime. 1 in 2. That's not a rare disease statistic. That is a near certainty for half of the women listening to this podcast right now. And the most predictable, the most preventable fracture in medicine is a hip fracture from osteoporosis, which in women over 65 carries a 1-year mortality rate of up to 20%. Now, here's the other number I want you to sit with. The decisions that determine whether you fracture a hip at 72 are largely made in your 30s and 40s, not your 60s, not your 70s. They're happening right now. And most women have no idea. Today, we're going to fix that. Welcome to Endocrine Matters. I'm Dr. Arti Thangudu, endocrinologist and founder of Complete Medicine and Hey Healthy. Today's episode is one I have wanted to record for a long time because osteoporosis is one of the most consequential and most preventable diseases in women's health, and it gets almost no attention until after a fracture has already happened. We're going to talk about what osteoporosis actually is and how it's diagnosed. We're going to talk about what determines your peak bone mass and why your 40s are a critical window. We're going to talk about risk factors, including some that will surprise you. We're going to get into what the evidence actually says about prevention. We're going to address the GLP-1 and bone health question head on because I am getting asked about this constantly. And we're going to talk about what screening looks like and what treatment actually involves if you need it. This is a dense episode. Take notes if that's useful. Let's get into it. First, let's talk about what osteoporosis actually is and why it's called the silent disease. Let me start with what osteoporosis actually is, because I think most people have a vague sense of it as brittle bones, and that's about as far as it goes. Osteoporosis is a skeletal disorder characterized by low bone mineral density, deteriorated bone microarchitecture, decreased bone strength, and an increased risk of fragility fractures. That last part, fragility fractures, is the clinical endpoint that matters the most. A fragility fracture is a fracture that occurs with no trauma or with trauma equivalent to falling from standing height or less. In other words, your bone breaks from something that it should not break as a healthy bone. It's diagnosed in one of 2 ways. Either you have a fragility fracture, full stop, regardless of what your bone density scan shows, or your bone mineral density measured by a DEXA scan, dual energy X-ray absorptiometry, is at least 2.5 standard deviations below the mean for a young adult reference population. That's a T-score of negative 2.5 or lower at the lumbar spine, total hip, or femoral neck. There's also a category called osteopenia, T-scores between negative 1 and negative 2.5. This is lower than optimal bone density, but not yet at the threshold of osteoporosis. It matters because it's where many women in their 40s and 50s will land, and it's where the prevention work is most impactful. So how common is this? In the US, approximately 20% of women over 50 meet DEXA criteria for osteoporosis. Among women 65 and older, that rises to 30%. These are not rare numbers. These are the numbers of a disease we have normalized and routinely failed to address until fractures are already happening. And here's what makes it so dangerous. Osteoporosis is almost completely silent until a fracture occurs. There's no pain, no warning signs, no symptoms. You can have significant, clinically meaningful bone loss and have no idea, which is exactly why waiting until 65 or something breaks to think about this is the wrong approach. Now let's talk about peak bone mass, why your 40s are not too late, but the clock does matter. Here's the foundational concept I want you to understand. Peak bone mass. Your bones are not static. They are living tissue that is constantly being broken down by cells called osteoclasts and rebuilt by cells called osteoblasts. Throughout childhood and early adulthood, the building outpaces the breaking, and your bone density increases. Peak bone mass, the maximum amount your bone will ever have, is achieved in the late 20s. After that, the balance shifts. You begin to lose bone mass slowly over time, and at menopause, bone loss accelerates significantly. Estrogen suppresses osteoclast activity, the bone breakdown side. When estrogen drops, the brakes come off osteoclast activity, and you can lose more bone per year than in the years before. So your lifetime fracture risk is determined by two things: how much bone you built at your peak and how fast you lose it. The higher your peak bone mass, the more bone you have to lose before you reach the fracture risk threshold. This is why what you do and what you eat and how you move in your 20s, 30s, and 40s has lifelong skeletal consequences. So what determines peak bone mass? Genetics accounts for about 60 to 80% of the variability in peak bone mass between individuals. So some of this is not in your control, but 20 to 40% that is in your control is profoundly important, particularly because it can move you from the lower end to the higher end of your genetic potential. The modifiable factors include calcium and vitamin D intake during the bone building years, physical activity, particularly weight-bearing and resistance exercise, maintaining a healthy body weight, not smoking, and limiting alcohol. These are not abstract wellness recommendations. They are inputs into a skeletal bank account whose balance you will be spending in your 60s and 70s. And if you are in your 40s right now, you have not missed this window. Bone mass continues to be malleable into midlife. You cannot build your way back to a 25-year-old skeleton, but you absolutely can slow the rate of loss. You can maintain what you have and meaningfully change your fracture trajectory. That is what this episode is about. Now let's talk about risk factors you may have and not know about. Let me walk through the risk factors for osteoporosis because several of them are under-recognized and one of them is going to be relevant to a significant portion of my audience. The obvious ones, older age, female sex, low body weight, a BMI below 20 is a specific risk factor. And I want to pause on that because we live in a culture that rewards thinness, and bone health is one place where very low body weight carries a real cost. Prior fractures and parental history of a hip fracture. If your mother fractured her hip, that is a risk factor for you. Genetics of bone density are heritable. Lifestyle factors, smoking and excess alcohol. For alcohol, the threshold in the evidence is more than 3 drinks per day as a consistent risk factor. This is important context. Moderate alcohol use is not a major bone health concern. Habitual heavy use is. Although if you have osteoporosis, alcohol may increase risk of fall, thereby increasing risk of fragility fracture. Medications. These are medications that can worsen osteoporosis. Glucocorticoids are one of the most significant and underappreciated risk factors in clinical practice. Prednisone, methylprednisolone, and other corticosteroids used for autoimmune conditions, inflammatory bowel disease, asthma, rheumatoid arthritis, and many other conditions directly suppress bone formation and accelerate bone loss. Even some supplements, specifically those for adrenal fatigue, not a real diagnosis, by the way, have steroids that can negatively affect your bone health. If you have been on oral or high-dose inhaled glucocorticoids for 3 or 4 months or more, your bone density should be on someone's radar. Now let's talk about medical conditions that can predispose to osteoporosis. Rheumatoid arthritis, inflammatory bowel disease, chronic kidney disease, and chronic liver disease all increase osteoporosis risk, both through direct biological mechanisms and through medications used to treat them. Celiac disease, if undiagnosed or poorly controlled, impairs calcium and vitamin D absorption significantly. And here's one thing I want my audience to hear clearly. Premature menopause, defined as menopause before age 40, is a major risk factor for osteoporosis. Every year of estrogen exposure you lose is a year of estrogen's protective effect on bone remodeling that you don't get. This includes surgical menopause, premature ovarian insufficiency, and any other cause of prolonged hypoestrogenism or low estrogen. If you went through menopause before 40 and you're not on hormone replacement therapy, unless you have a specific contraindication, your bones are on my mind. I also want to mention thyroid disease specifically because it's my specialty and it's directly relevant. Untreated or undertreated hyperthyroidism accelerates bone turnover. And TSH suppression from overtreatment of hypothyroidism, something we discussed in depth in a recent episode, is associated with increased bone loss, particularly in postmenopausal women. If you are on thyroid hormone therapy, your bone density is one of the reasons I take TSH targets seriously. So now let's talk about what you can actually do. This is the part I want you to take notes on. Resistance training and weight-bearing exercise. This is the most powerful modifiable intervention for bone health, and I want to say it emphatically. If you are not strength training, starting now is one of the highest leverage decisions you can make for your skeleton. Mechanical loading, putting stress on bone through exercise, is the primary stimulus for bone formation. Osteoblasts respond to mechanical load. Resistance exercises like squats and push-ups and high-impact or weight-bearing exercises have the strongest evidence for maintaining and improving bone mineral density. Balance exercises like heel raises, standing on one foot, are also important because fall prevention is fracture prevention. You can have excellent bone density and fracture a hip if you fall badly. The evidence is equally strong here. Reducing risk of fall is as important as reducing bone fragility. Walking is helpful and far better than nothing, but lower in impact than resistance and high-impact exercise. The goal is to do all of it. Calcium. The recommended intake is 1,000 milligrams per day for women up to age 50, increasing to 1,200 milligrams per day after age 50. The evidence strongly favors getting this from dietary sources: dairy, fortified non-dairy milks, leafy greens, sardines with bones, almonds. Here's an important nuance. The USPSTF recommends against routine calcium supplementation in premenopausal women due to insufficient evidence for fracture reduction, and there is ongoing research into whether excess calcium from supplements, particularly in women who already meet dietary needs, carries cardiovascular risk. This does not mean supplements are dangerous across the board. It means food first, and if supplementation is needed, make sure it's targeted and monitored. Next, vitamin D. The recommended intake is 600 IUs per day up to age 70, increasing to 800 IUs after that. Vitamin D is essential for calcium absorption. Testing vitamin D levels can be useful if there's clinical reason to suspect deficiency, like limited sun exposure, malabsorption, very dark skin. But routine high-dose vitamin D supplementation in women without documented deficiency is not supported by current evidence for fracture reduction and can carry toxicity risk at very high doses. Body weight. I want to address this carefully because it is nuanced. A BMI below 20 is associated with increased bone loss. This means that for women who are very lean, whether by constitution or by intention, bone density is a clinical consideration. This does not mean that higher BMI is universally protective. There are metabolic trade-offs at higher weights. But it does mean that the cultural pressure on women to be as thin as possible has a real skeletal cost that nobody talks about, and that aggressive caloric restriction has consequences for bone health. It's important to address secondary causes. If you have risk factors, ask your physician to screen for secondary causes of bone loss: thyroid function, vitamin D level, celiac disease markers, kidney and liver function, and critically review any medications that affect bone density, particularly glucocorticoids or steroids. If you have had premature menopause, the conversation about hormone replacement therapy and bone health should happen with your physician. Now let's talk about the GLP-1 receptor agonist question, because these are so popular today. I want to address this directly because I'm asked about it constantly in my practice, and because there is a lot of alarm online about GLP-1 medications and bone health, muscle loss, and overall body composition. Let me give you the actual current evidence. GLP-1 receptor agonists, medications like semaglutide and tirzepatide, do cause modest reductions in bone mineral density, particularly at weight-bearing sites like the femur and tibia. This bone loss correlates with the degree of weight loss. So the more weight you lose, the more bone density you may lose. This makes biological sense. One of the mechanisms by which body weight protects bone is mechanical loading. Carrying your own body weight is itself a form of weight-bearing exercise. So when you lose significant body weight, you reduce that mechanical stimulus. However, and this is a clinically important part, multiple meta-analyses have not demonstrated an increased fracture risk with GLP receptor agonist use. What this likely means is that while bone density measurements decrease modestly, the parameters that actually determine whether the bone breaks, bone quality, microarchitecture, trabecular bone score, appear to be preserved. Bone density is a proxy for fracture risk. If the proxy decreases but the actual risk does not increase, we have to interpret that carefully. The bone effects of GLP-1 receptor agonists appear to be driven primarily by mechanical unloading from weight loss, not by malnutrition. The concern about GLP-1 receptor agonist overuse causing bone loss through nutritional deficiency is not well supported in current literature. However, GLP-1 receptor agonists have been studied in obese or overweight patients. They haven't been studied in underweight individuals who are using them for cosmetic reasons. The promising data about bone mineral density in overweight and obese individuals using these medications cannot be extrapolated to those who use these medications to decrease their body weight below what is considered healthy. So while the data does not show that GLP-1 receptor agonists necessarily are harmful to bone, that is in patients who are appropriately using it. In patients who are overusing these medications, we cannot say that their bones are protected. My clinical takeaway: if you are on a GLP-1 receptor agonist, resistance training is not optional. The mechanical loading from strength training partially mitigates the bone loss associated with weight reduction. Make sure your calcium and vitamin D are adequate. If you have pre-existing osteopenia, osteoporosis, or significant risk factors, have a specific conversation with your physician about bone health monitoring. This is manageable. It requires attention, not alarm. So when should you ask for a DEXA scan? Universal bone density screening is not recommended for premenopausal women. The standard guideline is to screen women beginning at age 65 or earlier, beginning at 60, for women with risk factors. But if you have specific risk factors, you don't have to wait. And knowing when to ask is something I want to equip you with. Ask your physician about a DEXA scan before the standard screening age if you have a history of fragility fracture at any age, use of glucocorticoids for 3 months or more, premature menopause before age 40, a significant medical condition known to cause bone loss such as inflammatory bowel disease or rheumatoid arthritis, a parent with a hip fracture history, or a BMI below 20. These are the clinical flags that move a bone density conversation earlier. I feel that the 65-year age recommendation may be late for many women. When you get a DEXA, you will receive T-scores for the lumbar spine, total hip, and femoral neck. The clinically significant thresholds are T-score of -1 to -2.5, that's osteopenia. T-score of -2.5 or lower is osteoporosis. You will also likely get a FRAX score, a 10-year fracture risk assessment that incorporates your bone density along with your clinical risk factors. The FRAX thresholds that typically trigger treatment consideration are a 10-year hip fracture risk of 3% or greater, or a major osteoporotic fracture risk of 20% or greater. One thing I want to say about DEXA interpretation: it matters where the scan is done and who is interpreting it. Lumbar spine DEXA can be falsely elevated by degenerative changes, vertebral fractures, or calcified aorta, all of which are common in older women. If your lumbar T-score looks surprisingly good compared to your hip scores and you have significant arthritis, that number may not be telling you the whole truth. This is worth discussing with whoever is reading your scan. For most of the people listening to this episode, the goal is prevention, and what I've described in the last sections is your toolkit. But I want to briefly walk through what treatment looks like if you're already at the threshold of osteoporosis or have fractures, because if that is you or someone you love, you need to understand what exists. For patients at high fracture risk, T-score of -2.5 or lower, or FRAX thresholds met, the first line of treatment is anti-resorptive therapy. Most commonly used are bisphosphonates like alendronate, typically weekly oral, risedronate or zoledronic acid, IV once a year or every couple of years. These drugs bind to bone and inhibit osteoclast-mediated breakdown. The fracture risk reductions are real and meaningful. Bisphosphonates reduce vertebral fracture risk by roughly 36 to 56%, hip fracture risk by 26 to 42%, and non-vertebral fracture risk by 17 to 20%. The American College of Physicians 2023 guideline recommends bisphosphonates as first line due to their evidence-based safety record and cost profile. The alternative anti-resorptive is denosumab, a monoclonal antibody given as an injection every 6 months. It's more potent than bisphosphonates and reduces vertebral fracture by 68% and hip fractures by 40%. One important nuance about denosumab: do not stop it without a plan. Unlike bisphosphonates, which stay bound to bone after discontinuation, denosumab wears off, and stopping it without transitioning to another anti-resorptive can cause rapid, significant rebound bone loss and fractures. This is something I see happen when patients are on denosumab and then lose insurance or decide to take a break without telling anyone. Please don't do that without a conversation with your physician. For patients at very high fracture risk, T-score below -3, a spine or hip fracture with T-score below -2.5, multiple fragility fractures, or a fracture within the past 12 months, anabolic agents are preferred first-line therapy. These are bone-building medications rather than bone-protecting ones, and they have impressive efficacy. Teriparatide reduces vertebral fractures by 74% and non-vertebral fractures by 39%. Abaloparatide reduces vertebral fractures by 87% and non-vertebral by 46%. Romosozumab, a sclerostin inhibitor, reduces vertebral fractures by 73% and hip fractures by 38%, but carries an increased cardiovascular risk and should not be used in patients with recent stroke or heart attack. The key thing to know about anabolic agents: their effects are transient. You build bone while on them, but that bone is not permanent without follow-up anti-resorptive therapy. These medications are given for a limited time: teriparatide and abaloparatide for 2 years, romosozumab for 1 year, and must be followed by a bisphosphonate or denosumab. The sequence matters enormously. An anabolic agent followed by no anti-resorptive therapy is a missed opportunity at best and a rebound loss at worst. One final point: fracture liaison services, programs that provide comprehensive bone health management after a fracture has occurred, increase medication initiation and adherence dramatically. If you or someone in your family has had a fracture and was not connected to any follow-up bone health care, that is a system failure that happens all the time. You can ask for it. You have the right to follow-up bone health care after a fracture. Let me close with what I want you to actually do after this episode ends. If you are in your 40s, start strength training if you aren't. Check that your calcium is adequate from your diet. Think about whether you have any risk factors I described: glucocorticoid use, premature menopause, a parent with a hip fracture, very low body weight. And if you do, have a specific conversation with your physician about whether earlier screening makes sense for you. If you are already postmenopausal and have not had a bone density scan, ask for one. You deserve to know where you stand. If you've already been told you have osteopenia or osteoporosis and nobody has put together a real treatment plan with you, that conversation is overdue. The fractures we are trying to prevent are the ones that end independence, the ones that trigger nursing home placement, the ones that too often become the beginning of the end. They are preventable, but only if we talk about them early enough to do something. This episode may be the most shareable thing I've created. Send it to a woman in your life who exercises only cardio and has never touched a weight. Send it to the daughter whose mother fractured her hip. Send it to the patient who is still trying to understand what her DEXA results mean. I'm Dr. Arti Thangudu. You can learn more about my practice at sacomplete.com. This is Endocrine Matters. I'll see you next time.